Step 2 likes throwing pretty complicated patient presentations. However, the diagnosis can be very straightforward. Patient comes in with shoulder pain, slight Horner syndrome, maybe they have ptosis, meiosis, they have neurological symptoms of the arm, such as intrinsic hand muscle atrophy or supraclavicular lymphadenopathy, and let's say the patient has lost a lot of weight in recent days. What do you think this is? You should be thinking about Pancoast tumor. Smoking is the greatest risk factor for this. Step 2 loves risk factors, so remember that. Why do you have shoulder pain? You have shoulder pain because it's pressing on the brachial plexus. This is also why you have atrophy. Horner syndrome, well, your paravertebral sympathetic chain or your stellate ganglion lie there. And what about the patient's voice should you look out for? They can present with hoarseness. Rarely, but also it can be very dangerous. They have superior vena cava syndrome. But a big giveaway, especially when it's a patient presenting with some type of cancer, you look for the buzzword weight loss. Now, you can have a very similar case if the patient has reactivation tuberculosis, but remember, that arm pain or that atrophy of the muscle is highly uncommon. How come my patient doesn't have hemoptysis or dyspnea? Well, when it comes to those symptoms, you really want to think about some central airway tumors, such as bronchial carcinoid tumors, but these are pretty rare. Also, don't forget, because we're on the topic of some lung cancers, mesothelioma is a malignant neoplasm of the mesothelial lining of the thoracic cavity, but remember, the chest imaging is going to show pleural thickening with effusion. These are highly linked to asbestos exposure, and I kind of remember the pleural thickening because the asbestos, if you remember, they kind of line the ceilings of old houses and it kind of adds a thicker layer to the ceiling. So I kind of use this mnemonic to remember pleural thickening. The first line imaging study for the superior sulcus tumor is X-ray. And every time you're considering the diagnosis of some type of lung cancer, try to compare the X-ray to a prior X-ray. If X-ray is not an option, consider an early CT chest for all patients when you suspect lung cancer. Now that we're in the topics of lung cancers in general, just remember that early stages, the preferred treatment is surgical resection with or without chemotherapy. And if it's later stages with metastasis, remember that if there is a targetable mutation present, always use molecular targeted therapy. And if there's no targetable mutation, again, do chemotherapy and or immunotherapy. And I forgot to mention for those treatments, these are only for non-small cell lung cancers. When it comes to small cell lung cancers, if it's a limited stage, for all patients, you want to consider systemic therapy or concurrent radiotherapy. And if it's really extensive stage, remember that the treatment is palliative, not curative like it would be for limited, and it's chemotherapy with or without immunotherapy. I know that was a lot, but the pharmacology at the end there wasn't as important as the high yield subject of Pancoast tumors.